Thank you, sir. A very good morning. So I think this panel we will start where we left at the end of Dr. Smriti's talk, the controversial issue. She's a young lady who was actually undergoing investigations for primary infertility, found to have a 10 centimeter uterine query leiomyoma, underwent laparoscopic myomectomy with power morcellation. So for those of you who are not surgeons and have not seen what is done in a morcellation, this is a video. It's not the same patient's video, but just to give you a feel what we were discussing about contamination and spillage. This is inevitable. You know, you can imagine how there's no way you can prevent contamination. Unfortunately, in this case, the histopathology came as malignant mesenchymal tumor, query leiomyosarcoma. And let me tell you, this is not a very rare scenario in our practice. We do see such cases quite often. Dr. Smriti said 2 in a year, we must be seeing 2 to 3 in a month. So the question is, let me start with Neha. The outside report was a mesenchymal malignant tumor. Now, how important it's to have a proper pathology? Of course, we had discussion in the morning. Dr. Bharat Rekhi very nicely, stressed upon this point. What is important for pathologists, and how do we report when we get this sort of tumor? What is the optimum reporting?
Yeah, thank you, ma'am, for that question. And I think the role of pathologist in mesenchymal tumors of the uterus encompasses a diagnostic role, which is to distinguish between the various subtypes of different tumors, and especially distinguish between the benign, the uncertain malignant potential, and the malignant ones. Then accurately stage in a resected specimen, then prognosticate, and then predictive, the new and recent and ever developing role of predictive markers in sarcomas.
So is it necessary to do IHC in all, or how do you select? And what about molecular studies?
While it is always morphologically driven, we first and foremost evaluate the histopathology. And most of these cases will have a certain histological appearance. However, immunohistochemistry can be used in certain cases, as I said, to confirm the diagnosis, and in certain cases for performing the predictive or the prognostic markers. So that is why majority of these sarcomas nowadays you will see that some amount of immunohistochemistry is being performed.
Okay, thank you. So I think, of course, pathologists are important for all, in all aspects of oncology, but more so in uterine sarcomas because of rarity of this disease and also complexity. So it's recommended to have an expert pathology review before we proceed with the further treatment. My question is, and what we were discussing, and is Dr. Banas, let me ask you, does morcellation adversely affect oncological outcomes? Yes.
So yes, morcellation, a power morcellation will adversely affect oncological outcomes. Because as we just saw the short video, that the seeding is the spillage is inevitable, and of course every patient will have a different kind of a biology, whether it will get seeded in the peritoneal cavity or not, which is very difficult to make out. So a good workup with such a history, patient coming in with a history of morcellation from outside, that's how we get the patients. And then a good workup is important to know, but yes, overall a morcellation would affect.
Yeah, so there are many studies, of course there cannot be a randomized trial on morcellation versus no morcellation in sarcoma, but many retrospective studies have in fact shown that morcellation adversely affect both DFS and OS in these patients. And in fact US FDA has issued a black box warning not to do uterine morcellation for suspected leiomyoma, and there have been many litigations in the West. In India, I think we are fortunate, we have not heard any, but we do see such cases happening quite often. So coming to our patient, we reviewed her slides and blogs from TMH, and the diagnosis of leiomyosarcoma was confirmed. The next question is, how do we work her up further? Dr. Nilesh, what is the best imaging modality in a suspected sarcoma and in this kind of situation?
Thank you. For the suspected case of uterine sarcoma, MRI is the best modality of choice.
So you think, I mean, if what's the role of PET versus CT versus MRI? What do you want to do, and what, you know, as a clinician, I may be interested in knowing both local as well as distance meds.
For local staging, MRI is the best because it gives us best soft tissue contrast. And if you are suspecting for the metastasis, then we can go for the PET CT.
Right. So let me take opinion from clinicians. What would be the imaging modality of choice?
I think this is one of the tumors where gynecologists deal with it rather than gynae-oncologists. So I think if you see gynecologists practicing, they would just do an ultrasound and then they say, okay, it's a fibroid, let's go ahead and do surgery.
True.
I think that's very common scenario as compared to...
Yeah, so true that's the what is done usually. And yes, but then there could be a particular type of patient, a postmenopausal patient who has a growing tumor. In that a gynecologist or a gynae-oncologist would get an MRI done. So to achieve a pre-operative diagnosis, MRI is a modality of choice. However, in a post-operative evaluation, then CECT has a certainly better role.
Kaustuv.
We must understand that leiomyosarcomas are prone to distant metastasis, and we should never forget to do distant screening, whether in the form of a PET CT or maybe a CT thorax and a MRI for the primary CT chest or a whole body PET CT, but distant metastasis should never be omitted, because almost 33 to 35% patients have a propensity of distant metastasis.
So I think what I understand, MR has actually poor sensitivity of making pre-operative diagnosis of leiomyosarcoma versus leiomyoma. Degenerated leiomyoma versus leiomyosarcoma is often difficult. What is the sensitivity, Nilesh, of MRI?
So actually it is the MRI plus LDH which is used, so-called used to try and diagnose a leiomyosarcoma pre-operatively. It is not a CT scan which is used for evaluation pre-operatively. And first, the most important thing is to get actually a histopathological diagnosis initially. Only those women who would have a complaint of bleeding PV, yes, we know that the tumor has eroded through the endometrium, so that's why she's bleeding, and we'll probably get a biopsy positive in that. And that sensitivity is somewhere between 33 to 63%.
Okay, so let me.
So it's a very low sensitivity.
Controversial point, Dr. Jaydeep. Dr. Manas said the diagnosis of sarcoma is required. Is biopsy okay pre-surgery to get a diagnosis in case you want to decide on the route of surgery, lap versus open?
Now, if you had a case like what Professor from Japan explained, that you have a uterine polyp and you take the biopsy from, that's okay. But if I see a fibroid, especially, of course, it's a matter of education for the gynecologists rather than for gynae-oncologists, because we see referred cases. And majority, 60–70% of the women will have a fibroid at some times in their life, and they will go to a gynecologist for that. And based on what they see on the ultrasound, an operation will be done. And myomectomy if they are young patients. Of course, if they are not young patients, they will have a
So my
hysterectomy.
question is, if on imaging it is suspected to be a sarcoma, is it okay to go ahead with biopsy?
I would not do a biopsy in case if it's like a present like a fibroid. If there's an intrauterine lesion, which I can biopsy with a pipelle or a hysteroscopic biopsy, that's okay.
Sure. Yes, Umesh.
I think the only indication is when you have both primary and pelvic nodal disease inoperable at diagnosis. That is when you will have to really think of doing a biopsy. Okay. Otherwise, I think if primary is operable, always you can go ahead and do.
Okay. So one quick question before we move further. If a laparoscopic surgery with morcellation in the form of total abdominal hysterectomy is done, is there any role of subjecting this patient to another surgery, knowing well that there was a spillage and this thing, if post-operative imaging is normal?
No, I didn't get the question, because you said total abdominal hysterectomy.
Laparoscopic surgery with morcellation, uterus was removed, but the final histology is a leiomyosarcoma. So is there a role of going in again?
So So first and foremost, most of us, as well as the literature suggests that whenever there is a uterine fragmentation or a supracervical hysterectomy, which is also seen many situations, one must do a thorough imaging workup, and a workup is done with mainly by CT scan of the abdomen, pelvis, and chest, not to forget the chest, which is very important. And yes, there could, many centers would put in a scope and see if the seedlings are there, if it's frankly there. But then tumor board sometimes decides, practically I am saying, that since this patient is a high risk, so the, she would get adjuvant chemotherapy, so why do the, at least why do the laparoscopy? But yes, imaging study has to be done.
So if I can come in, if there is a normal imaging post-morcellation, would a gynec oncosurgeon go in and operate and redo the surgery, complete the surgery? Is the question, I think, what you wanted to ask.
So most of the surgery is a hysterectomy with bilateral
That's already been done.
Yeah, that's already been done. So there is no particular need of actually going in and doing a completion surgery, because lymph node assessment, is not required, and neither is peritoneal cytology required. So imaging plus minus laparoscopic viewing and analysis.
Right, so there are studies suggesting if there is no disease seen on imaging, surgery may not be of any use, although these patients do have increased risk of relapses.
So my question is for the surgeon, like what Dr. Vishwas told that the gynecologist has to be educated. So what is the role of hysteroscopy in this? Can't we do a hysteroscopy prior and get an idea and then go for surgery?
So any woman who has had a postmenopausal bleeding, we will evaluate the endometrium. We will not think of sarcoma at the first instance because of a very rare tumor. So for any evaluation of an abnormal uterine bleeding, either we do a endometrial aspiration biopsy with PIPL or whatever equipment you have, or you do a hysteroscopic biopsy depending on the situation. So that would be a biopsy done to evaluate the postmenopausal bleeding, not to diagnose a sarcoma. But
so thank you for that question actually. So Cochrane analysis has clearly stated that MIS is there to stay. There are far more benefits of doing a laparoscopic surgery for fibroid uterus than otherwise. But what we have to educate the gynecologist is that there are certain situations like a postmenopausal growing tumor, a woman exposed to tamoxifen, pelvic radiation, or a history of young retinoblastomas. There are certain hereditary situations. In them, do not do a laparoscopic surgery. Also, if you are doing these cases, use colpotomy, mini lap. You can always extend the incision after doing the laparoscopic myomectomy and take out the myoma as a whole, or do a manual vaginal morcellation, or do a endobag power morcellation. So it so happens that, even in our institute, one of the finest laparoscopic surgeon is there who does good, endobag morcellation. But then when I personally tell him that it's a nulliparous woman, please do endobag in this one. So then he does endobag because it takes time. And most gynecologists would not be doing endobag morcellation. Okay. So that's where you can educate.
Okay, so quick comment from Dr. Rupinder and then Sampada. I'll come to you.
Yeah, just a quick comment that hysteroscopic biopsy or even a PIPL biopsy might not give you the diagnosis in LMS.
Yes, in fact, 90% cases it's going to the only possibility if it's a ESS which is projecting in the,
Sorry. Yes, that is correct, because leiomyosarcoma diagnosis requires a combination of three things: marked pleomorphism, necrosis, and increased mitosis. And all these areas, these three features may not be represented in a single biopsy from a focal area. Number one is that. Number two, I would also like to bring in the situation where an elderly woman with a polypoidal mass in the uterus, which has been biopsied by a PIPL, a carcinosarcoma. The sarcomatous component may actually be of a carcinosarcoma, and now we know that carcinosarcomas are carcinomas and not sarcomas, so that always remains in the differential, because in the biopsy the carcinomatous component may not be represented.
Okay,
I have one question to ask.
You have experts, all us, you are surrounded by
because
them.
As I said already that even with the endobag morcellation, it is better for the young patients. But the research and the retrospective studies, because many of them are retrospective studies only, and even with the best surgeons, there is a 9.4% risk of abdominal cavity spread.
Right.
So are we going to accept that without
No,
doing
it's
surgery?
not acceptable. So I think we move on to the next. Okay, otherwise we'll end. Our time will be up.
I think the data tells that.
So I think what we are trying to say is we have to be careful and judicious pre-operatively while selecting cases for MIS. Okay, so Sampada, you see any role of uterus preservation in any of the sarcomas? A young lady, nulliparous.
In sarcomas, no.
Yeah, I think the message is clear. What about ovarian preservation in our patient or otherwise? Are there situations where ovaries can be preserved in a young patient?
If it is only for the fertility preservation, maybe low grade ESS, we may preserve, explaining the risk that there might be an increased risk of recurrences. But except for fertility preservation, I don't think so. Ovarian preservation, even because they are ER/PR positive and there is an increased risk of recurrence, we should not be preserved.
Yeah, yes, Dr. Shalini. So, what about LMS?
LMS, the SEER review says that preserving ovaries has not increased the risk of recurrence as well as...
Right, so that's important more than actually, because many patients undergo just simple hysterectomy. Outside the question comes, do we go in again, remove ovaries or not? So in uterine leiomyosarcoma, I think we can leave ovaries behind. There is no need to do another surgery. Yes, Dr. Shalini?
Yeah, when you're talking about uterine preservation, there are some pediatric sarcomas in which they do conserve the uterus. So that's not extrapolated to adult sarcomas as of now.
So as such, those sarcomas are extremely rare in adults. So rhabdomyosarcomas are those kind of sarcomas, and we have
so
couple
it is
of
possible
cases
to preserve in one odd case, maybe not routinely. So
right. So
and another word about what is the robustness of LDH in diagnosing leiomyosarcomas, maybe the subtype of LDH.
Yeah, exactly. I am not sure.
So it's got a very poor correlation. Even with MRI plus LDH, very, very poor correlation actually.
Yes.
So CA125, LDH, MRI, they have a very poor correlation. So they have come out with something else also. There is the NLR ratio, neutrophil platelet ratio, and neutrophil lymphocyte ratio and platelet lymphocyte ratio. So these are all the markers. So NLR and PLR, they have to be pre-op, and it is seen that NLR has a correlation with adverse PFS and OS.
Okay, so let's come back to our patient. After having a detailed discussion, she opted to undergo surgery along with the removal of bilateral ovaries also, and there was a 2 millimeter deposit in pouch, and the diagnosis was a leiomyosarcoma with deposit. The question is...
so now we as medical oncologists, radiation come after the surgeons have finished their morcellation and the other things.
You are too close to it.
So now the serious things. So come down to the radiations first, and I know I'm a medical oncologist, so I can take the privilege of coming to you last. So any role of any adjuvant radiotherapy, especially, let's stick two scenarios, Kaustubh. First, there's a morcellation has happened, and that's the patient you have got, and second, the patient does not, and that's a proper gynec oncologist who has done a good surgery, may have preserved the uterus, may not have, that's a different job altogether, but the uterus is taken away, the ovaries may be preserved. So what is your role on an adjuvant setting for radiotherapy where a proper surgery has been done, and part two, when a morcellation has been done?
So in leiomyosarcomas, both these situations, no role of radiation.
No role of radiation.
In leiomyosarcomas,
okay,
it would be different in undifferentiated and ESS. There will be certain situations where we may consider radiation. LMS, no role of radiation.
So in ESS, you would give radiotherapy in what setting?
High grade, advanced tumors, extrauterine disease. Those are the situations where case-to-case basis you can consider, because none of the trials have shown. One trial has shown, propensity towards overall survival, but it was not statistically significant. So it has to be selected and it has to be on case-to-case basis. If you go by broad guidelines, there is no robust data of adjuvant radiation in any of the settings. Having said that, a lot of guidelines say we would err towards adjuvant radiation in these settings where it's high grade, advanced tumor, extrauterine disease in ESS, and of course in undifferentiated.
Dr. Umesh, any difference in opinions?
I agree with Kaustav. The other indication I always tell is when gynae oncologist insists that you have to give pelvic radiation. I think that's the single most indication when I consider
how many
this
times in your for 50 years of practice you have experienced that?
No, it does happen in tumor board that, oh, no, please give this this patient.
So that could be a scenario where you are talking of a R1 resection and they feel the radiotherapy helps. Does it really help?
Yeah. So before I go to this.
Can I comment?
Yeah, go ahead.
Actually, in our tumor board, we say that there is no role of radiation therapy. Our radiation oncologists say that no, you should give radiation therapy for I would say the proper, or you can say the pelvic control of the tumor.
I come back to what
But
Amita
I have one question. Is there any role in the recurrent setting where you have excised the tumor? Maybe it is the pelvic tumor or the pelvic recurrence. In this kind of a situation, do you think that there is a role of the radiation?
So the dictum is that we have been discussing this, that surgery is the treatment for sarcomas. So as many times surgery you can do, that's the best option for the patient. But if surgeon says no, it is inoperable, or we do a cytoreductive surgery, then definitely there is a role in that situation, but only to have some local control or pelvic control rates, not in terms of overall survival.
No, the question is that after having done a resurgery, when the tumor is taken out, then do you
that's a
radiate
complete
the back?
removal.
So that was the question.
So that is the indication when surgeon says no, you have to give.
Okay, so basically that's a perception-based practice rather than.
I wanted to come back to what Amita presented in that data. Please be very careful. The data was hardly of 40 patients, where adjuvant radiation was given, adjuvant chemo was given in 60% in power morcellation versus no morcellation. And of course, graphs showed that they are hugging each other, but p-value is 0.02. If you consider p-value 0.02, yes, you are correct. But if the numbers are so low, you have to be very careful, and that is why I always say individualize the treatment. That is why in tumor board, if somebody insists, we have to give, go ahead and give.
Yeah, please.
Stage 2 LMS, based on the size criteria alone, but completely resected. Is there a role for RT?
So let me just quickly put staging here, because many of us may not even remember staging of sarcoma. So this is the staging. It's slightly different from carcinomas.
So the cost of sir, you want to take it?
I will just say, I think the lighter side, it was there earlier. We have worked in a different, say, institution. When you go to a different institute, there are certain changes that happens. If you have something which you have to give a number in an institution, then you have to give radiation. If there is no number on your behalf, then you need not to give any radiation.
More numbers, then actually your indications may change.
Okay,
so no, the answer to her question is no radiation in stage 2.
No radiation. Okay.
Can I add one thing? When I was doing my residency, the thinking was that in LMS, there is a high propensity for lymph node metastasis. But now data says that it is less than 6% in early stage, that is stage 1, stage 2. But when we were doing residency, these data was not there. So that time, historically, we always gave pelvic radiotherapy.
Right. So in fact, now in LMS, lymphadenectomy, routine lymphadenectomy is not indicated unless nodes are enlarged.
So basically, what has come out of radiotherapy is don't refer it to a radiation oncologist. There is actually no role. That is the thing that's coming out. So, but yes, there are situations which has been eluded, and basically cervical involvement is one area where radiotherapy is normally indicated. That cost of elucidated other than the other risk factors. But the high grade and size, there is no much data on a level of evidence to postulate that, to recommend radiotherapy. So my medical oncologist colleagues, Ashish, first to you. Have you ever thought of, let's say, our radiation oncologists plan a radiotherapy? Do you think a concurrent chemotherapy would be beneficial? Point number one, provided the radiation has been planned. That's the first initial question. No concurrent chemotherapy.
Yeah, your mic, I think.
I think it's not working. is still not working. So what he tells is no concurrent chemotherapy. There's actually one data of radiotherapy plus chemo versus RT alone. There was a DFS benefit but no OS benefit. So that is the only one trial that is there in this scenario. So coming down to Gangotri, so this would be for you a stage 2B because of that POD deposits. I assume that's it. So is it the initial which was not pre-morcellation, or would you take it on now because the POD deposits are there? You assume that was because of morcellation and then you treat this patient as a stage 2B, or would you treat it as a pre-morcellation staging?
Because the surgery was done immediately. So
Okay.
I don't think 2 millimeter deposit pouch of Douglas will be there immediately after morcellation.
If a patient comes to you after 1 month, do you think that that could have happened because of the deposit from morcellation?
Yeah, of course, it's because of morcellation only. I mean, it was, but the question is how do we stage it her now? Okay.
So, so Dr. Ashish, would you take that into consideration and plan adjuvant chemotherapy?
I think you said the patient is 49 years old, right?
Yeah.
So I would consider in this case chemotherapy.
So RT and CT is gone. These are the options which I could find, and you at RT alone is normally not done except for a rare scenario which has been elucidated. So for chemotherapy is your yes to chemotherapy.
Yes.
What are the factors and what is the evidence for you to plan for a chemotherapy in this lady post morcellation?
So I think here it's a leiomyosarcoma, then morcellation has been done, we know that which we know the increase the risk of spillage, and we have seen a POD deposit. So these three factors are
okay.
Kind of...
so if there would have been no morcellation in a stage 2, would you advocate adjuvant chemotherapy?
No. In that
let's
situation,
a size is 7 centimeters and it's a high mitotic grade and it's high grade.
If it was completely resected without morcellation, there is no POD deposit, I assume that.
Yeah.
So in that situation, I would say no.
No. And for that a patient which you thought of, what would be your chemotherapy? Would it be a single agent or a combination?
Again, no real data to kind of support one versus the other, as Dr. Smriti Madam has showed in her talk. So, but my preference, because she is a younger woman, I would prefer the GOG regimen, gem dosi for 4 followed by adriamycin into 4.
Gem dosi followed by 4 cycles followed by the adriamycin 4 cycles.
That trial.
Okay.
But I mean, anybody could be right here. If somebody uses single agent, I think they would also be right.
Dr. Gangotri, any opinion on this part of the chemotherapy?
All the questions or just question?
In post-morcellation, would you recommend chemotherapy?
The question is, I think, whenever you decide to give
Okay.
chemotherapy frontline, which one, what will be?
And it's a single agent or combination?
Single agent.
Single agent. And
Patient is saying, so I can...
so single agent. What is the drug and what dose?
Doxorubicin.
What dose?
60 mg per
60 and 8 cycles.
cycles.
6 cycles. Okay. So basically, if you look at the data, even post-morcellation, there is no data of a higher level to even advocate chemotherapy, and there is no data to show that it is advantageous. And if you look at it, the assumption is because the spill has happened, that is why you would be benefiting. Yeah, you wanted to say something.
Coming back to the question we started during the lecture, if you do open surgery, what would be the stage in morcellation? If you do lap, what would you take it as stage if you think that there is spillage? Question to surgeons.
So open surgery, we would not be doing morcellation.
Okay.
You would
That's
not.
very clear.
No spillage.
No,
There is no spillage.
No spillage.
So then you would consider lap
Yes,
as
we-
stage 3?
So
No,
stage 2
so I have a query and a question, both ways. So, as per the classification staging, it is, 5 centimeter and more and 5 centimeter and less. So usually the staging is made because if there is a sub part of a staging to indicate prognosis as well as treatment. Now, if a morcellation has been done, tumor is more than 5 centimeter.
Yeah, by and large.
By
But
and
unless you
large.
are doing a myomectomy,
No,
you may
I'm
have
not,
to even
I'm not
morcell-
debating that.
Yeah.
The debate is if you consider morcellation as pelvic peritoneal contamination, then it is stage 2. In stage 2, adjuvant chemotherapy or radiotherapy doesn't work. That is
So,
what I was trying to
to
say.
be honest, Umesh, we don't know whether it is stage 2
Yeah.
or 3 because we don't know. It
Staging is
happened
not
in
clear
the
then.
entire cavity.
there is a control
Because
same
there could be a
stage, there is
deposit
control
even
same what
before the
stage.
surgery.
Rohit?
Yeah. Can I ask a question to the medical oncologist? Is any amount of chemotherapy, radiation going to prevent a peritoneal recurrence when somebody has morcellated a leiomyosarcoma?
So that opens a window for HIPEC then.
Okay,
Okay,
we'll
we
come
will do
to
that.
that quickly.
So, yeah.
The time is getting.
Yeah, quick.
Can I ask one question? Actually, whenever we are seeing the patients or those who have experienced, we find that these patients keep coming to you with the recurrences.
Yes.
You do surgery and within another 6 months or 8 months or 1 year, they will come up
They will
somewhere
always come back,
else. So
irrespective.
it is basically not the pelvic only, one can say that the contamination, it is the peritoneal. This is what the
Absolutely, and
experience
including port site and other sites.
Okay, quickly,
Can I ask?
we will move on. We have 15 minutes and we have to complete a lot of things. So now, Dr. Ashish, again, leiomyosarcoma, would you advocate adjuvant hormonal manipulation? And if yes, what and in which subset would you do that?
So you have not mentioned ERPR positive.
Yes, it is positive.
So in this situation, yes, I would try hormonal therapy. The amount of benefit is difficult to say, but studies.
And what would be your hormonal agent on an adjuvant setting?
So aromatase inhibitors, and the duration
AIs.
would be typically 5 years.
Dr. Gangutri, any difference or is same? Same. Okay. Please, you speak into the mic because no one is here.
Either letrozole or metroxyprogesterone will be the question.
Which one?
We generally use metroxyprogesterone.
You use the metroxyprogesterone. Okay, these are the data for the adjuvant chemotherapy studies. And if you look at it for the early stage, you have the doxorubicin 8 cycles actually. It was the trial which was normally performed was 8 cycles. It is 60 per meter square. And this showed no benefit over observation. The point is there is one more study of 50 versus 70 of doxo. And that showed that 70 is superior to 50. So is 60 a good dose? No one knows. But if you are using 78 cycles would not be possible because of the cumulative dose of doxo. Now go back, and this is what Ashish told, the Hensley data, which was GEM, DOSI, 4 cycles followed by DOSI. It was a phase 2 data, single arm. The 3 years, the 2 years, the DFS was approximately, 78%. So this is what really encouraged people to do the phase 3 trial. And if you look at it, as Madam told, this phase 3 trial planned for 200 odd patients, landed up with only 38 patients. And this again 30 patients was presented, and this trial, GEM DOSI versus observation, was again a negative trial. So there was no benefit also on this study. And there is 2 data sets, anthracycline versus GEM on a retrospective analysis. And this is the best you can find for a comparison of a GEM DOSI versus doxo. And this showed, whatever the data may be criticized, this is the best you have, that docetaxel is superior in DFS and numerically superior for OS. So all that points out today for adjuvant setting, if one has to plan chemotherapy, probably single agent docetaxel would be the way to go forward for whatever evidence you have, if you at all think for that. Although there is no data to be told that after morcellation event, there is a evidence that adjuvant chemotherapy really makes an oncological outcome difference.
You meant the single agent adriamycin,
Adriamycin.
not doxy.
Doxo, I told doxo.
Doxo.
Yeah. So adjuvant RT has been spoken, the cervical stromal involvement. And would you use a brachytherapy? That would be sufficient. Dr. Kostov or anyone? Yeah, please.
So Mahesh will say whatever surgeons will do.
A quick yes, no. Would a brachytherapy be sufficient?
I don't think we should offer brachytherapy for these patients. No.
It's external radiotherapy if you want
External
to.
radiation. So my principle is very clear. If you have a gun loaded with bullets, don't fire them unnecessarily. Keep them, reserve them when it is required.
Okay. So there is again a little bit of data which is not there, but yes, there is individual preferences. Addition of chemo to radiotherapy, as I've told, is not a standard. DFS could be superior. For IHC, if you look at the hormone positive, again the data set is very, very different in metastatic versus adjuvant. If you look at the metastatic data in the adjuvant data set, the ER positive subsets do much, much better. Per se, limited uterine disease, the median survival was not reached if it is ER positive. So is it that the biology is so good that irrespective give a hormone or don't give a hormone manipulation, it is good enough? But if you have the data set, there is no much data for aromatase inhibitors in adjuvant setting. The best data set that comes on a retrospective analysis for the endometrial stromal sarcoma, that's where most of the things are used, is actually the progestins. The progestins are the only data set in adjuvant that has shown a benefit. AIs do not have much of a data. The numbers are in single digits, and you would not see any evidence in the adjuvant setting. So that is what it was, and tamoxifen is contraindicated, as was told by Dr. Smriti, so I won't go into details of that.
So this is just to kind of summarize what we already discussed, that stage 1 by and large observation adjuvant treatment doesn't really help. Anyways, stage 2 and 3 very, very controversial. Observation versus chemotherapy versus radiation therapy, but there is no good. Yes. Yes, and or.
The level of evidence, if you look at the footprint which is missing, is very low.
Very
so
low.
That also helps.
Right.
Yeah.
So these are some of the prognostic factors one may take into consideration while deciding adjuvant therapy in borderline type of cases: age, tumor size, grade, cervical involvement, and mitotic count. Coming back to our patient, actually, as per our protocol, we gave her 6 cycles of adjuvant doxorubicin. She was free of disease for 20 months. But then later she experienced recurrences at port site without and in the pelvis, but there were no distant mets, and PET CT was done. So the question comes, role of secondary cytoreductive surgery in recurrent setting. Sampada?
She has a disease-free interval of 20 months, and if it is a resectable...
How would you select cases for secondary cytoreductive surgery, if at all?
It should be a resectable disease, good disease-free interval, and performance status of the patient.
Okay. And of course, number of metastatic. Now comes the question what Umesh was saying, what's the role of HIPEC here? Okay, Dr. Manas?
Or even post-morcellation.
No.
Or even post-morcellation.
No HIPEC. There's no.
Umesh?
I think looking at rarity of this disease and so many controversies regarding surgery, adjuvant treatment, I think there's a strong case for doing good research in a prospective registration study, and you should be able to get some answer for this.
So that's the correct answer. Currently there isn't good evidence to suggest HIPEC. It's only in research setting, and I personally feel a tumor which is not chemosensitive anyways, putting it intraperitoneally or intravenous is not really going to make any difference. So by and large, yes, no to HIPEC in this scenario. So this were, we did secondary cytoreductive surgery, and Bill can skip.
So can I ask a question? When we are doing a first time surgery, at that time we should be excising the port, because morcellation was done. We should be excising the port site upfront rather than for the waiting for the recurrence to occur.
So all ports sites should have been excised.
Yes.
Which again means that you're taking up the patient for surgery again. So I just wanted one clarification in this. So this patient had a deposit, you said, right in the beginning. How big was the deposit?
2 millimeter in the pelvis.
2 millimeter on imaging?
No, at surgery. During surgery. So
which was taken out?
Lap myomectomy.
Which was taken out?
Which was taken out.
Okay, Dr. Ashish, any role of systemic therapy post-port metastasis, and you have done a R0 resection. The radiation oncologist was quite clear when you asked that they do not want to give radiotherapy even at this point. So any role of systemic when you have already given doxorubicin and there's a
Umesh, any change of mind now? Would you want to give radiation?
No, if this patient had only pouch of Douglas recurrence and you are not able to debulk completely R0, then maybe there is a case for local radiation. But if you have achieved complete resection both at the pelvis as well as the port side, then no.
Dr. Ashish, any quickly?
So, I think you mentioned about 6 cycles for doxorubicin.
Already given 20 months
of hormone therapy. What was
given? It was not given at that point.
No, but it was ER positive.
Yes,
as you mentioned. So then I think in this situation, I would consider hormone therapy.
Okay, you would consider hormone therapy. Again, the data is very sparse. You would not get any much data. But again, the take home would be in R0. Again, the adjuvant protocols really predominate, and the whole discussion what we did for adjuvant would come in. So patient was observed after this.
Dr. Sahoo, just a small clarification from my side also. I think more than ER, PR is more important because you are going to give medroxyprogesterone. ER has no much
if you
value.
give the progestins, actually the mechanism of action is again to the ER pathway, Again, it is not, Dr. Ashish, you wanted to say something quickly?
No, I think prognostically PR has a better outcome.
But if you look at the progestins, it acts through the liver metabolism, it stops the androgen to going to the estrogen, and again it also downstages the ER pathway and also metabolizes the estrogen. Yeah,
From a pathology point of view, leiomyosarcomas will always be more ER positive, and endometrial stromal sarcomas will always be more PR
Yeah, and the percentage would be around little bit, around 60, the data is 30 to 70% or 80%. That's how the positivity pattern is. So patient now develops lung metastasis. The last 5 minutes is to medical oncologist. So now we are the last.
I disagree.
We are not going to give this patient to you for carbon iron. That's for sure.
Now Umesh wants to do whole lung radiation.
No, that's not going to happen.
No, Dr. Sahoo, let me conclude by saying that if there are limited lung metastasis, if you are able to resect, you can resect.
I've written that multiple. So I knew this will come up.
Less than 5.
So it's multiple. No, not an oligometastatic definition. So after 15 months of the observation, now they develops lung metastasis. Dr. Gangotri, any investigations of the, you look at immunotherapy at this point, you look at the BRCA which Dr. Smriti spoke about, or would you not just investigate and just plan systemic therapy at this point?
I will plan systemic therapy.
So nothing more of a molecular diagnosis at this point?
The patient is affordable.
The patient is very much affordable.
So I will do it, but whether BRCA is, if I give chemotherapy or based on BRCA, if I give PARP inhibitors, and there is no much evidence in PARP inhibitors, I will go ahead with chemotherapy.
Okay. So the point is you can do the testing. As Dr. Smriti has told, there's a lot of things that are coming to a mutation analysis, but would you act on that? On the front line, no. You may do the BRCA is something on a somatic, you can look at it. You can also look at the different pathway. There are a lot of mutations, but there's no actionable mutation at this point of time. That's what was spoken.
So Tarini, what I would do at this point of time is that I would biopsy the lung mets and send it for comprehensive genomic profiling.
You can.
Just
and
to
you
have
will,
the information.
And you to act later
Since
on.
the patient has received doxorubicin, I will move to gemdosi and see if that works for this patient, because she has multiple lung metastasis. Probably the disease is behaving a little bit aggressive now. Also, there is some benefit of checking for ESR mutations. In case if there are ESR mutations, then one could try fulvestrant. And of course, then based on the CGP, if you get some molecular markers, you can try immunotherapy and other treatment options.
The chances of getting a positivity pattern for doing immunotherapy is very, very rare. The BRCA.
But some tumors are known to be hypermutated, and but of course that proportion is very small. I agree.
So re-challenge with Adria is out because you cannot go ahead and do the dose once again. 6 to 8 cycles already received. The gemdosi is the go-to drug. That's what we are getting. Would anyone consider pazopanib now, or would you consider post-failure of the gemdosi?
I will consider pazopanib later.
Later. Okay. So if you look at the data now, let's assume a patient has not received doxycycline, has come to us a metastatic disease. Would you give gem-docetaxel versus doxorubicin? And if you look at it, there is a data for doxo versus combination of doxo with ifosfamide. The data shows the combination is not superior with additional toxicity only. If you look at, there's one data here comparing gem-doci with doxorubicin. And this data again showed one thing, that doxorubicin is actually not bad enough. It is actually numerically superior to the combination. So third thing, it is the best I could find, is a propensity score matching analysis. This was when you do not have direct evidence of comparisons, and when they looked at it, they looked at doxorubicin with dacarbazine, doxo ifosfamide and doxo alone. And this is nothing, this is taken with that, it's not a randomized trial. 30% were uterine leiomyosarcomas, and this showed, with whatever criticism it is, that the doxorubicin with dacarbazine had the best evidence of the survival. So trabectedin, anyone has any experience, Dr. Ashish, on trabectedin?
No, I have not really used.
Okay, so this,
I mean, I've used for other indications, but not for.
But if you look at the data, the maximum responses has come with this drug. 60% response rate has come with trabectedin. That's why it is the trials are ongoing for the phase 3 for this drug. Bevacizumab, madam showed no benefit at all. So coming down to eribulin, no, because the data was mainly pushed by the liposarcomas. The leiomyomas did not do that well. Pazopanib, regorafenib, there is data. So quickly, PARPs, or you spoke about it, there is a case studies, you won't get report series, and there is data that if you add PARPs to temozolomide, or even trabectedin is being tried, you would get responses of around 25 to 30%. Anyone would use this? DPD, platelet-derived growth factor?
That drug, no.
Okay. It's a negative trial. Announce was a negative trial. Doxo versus the targeted therapy plus Doxo was a negative trial. Quickly, last 20 seconds. Now, if you want to use a hormonal therapy, Dr. Gangotri, would it be aromatase inhibitor or progestins? Quickly, we have only 20 seconds.
Not so far exposed to that.
Okay.
So I will expose it to hydroxyprogesterone.
Okay. So here actually the data is more towards equal for both on efficacy, but aromatase inhibitors is more convenient, more of a tablet form, lesser toxic, and you can achieve the dose. That's why aromatase inhibitor has a more bulkier evidence, and you normally use it in low grade ESS. I'm just going to skip this. The future is there. We have lot of mutations, as madam told. The pathways are there, but we are yet to get a drug to target the pathways. So take home. Yeah. So for surgery, it is definitely a yes. We spoke about it in frontline, relapse, limited, and metastectomy. If it is limited, you go for surgery. That's a go-to regimen protocol. In extrauterine spread, relapses are very common. You find the 5 years DFS for an extrauterine spread to be around 20-30%. And the morcellation should be avoided and condemned. That's what the whole panel was all about. The half the time went for that subset of patients. Secondary cytoreduction and metastectomy in a select few, you have to choose it. Role of RT limited, as rightly pointed out. But yes, in the tumor board, one more indication if the surgeon pushes for it. That's one thing we got from this panel. At best, it has a PFS advantage with chemotherapy. Adjuvant chemotherapy, people feel that there is a perception of higher, bulkier disease, poor disease criteria you would go for, because the 5-year survival is so low, especially in the stage 3, but there is no much data, but all of us do chemotherapy at least in the stage 3 and beyond, and single agent is as good as the combination, you can go for that. Observation versus chemotherapy, there is no difference actually. Adjuvant hormones, progestin have the best evidence in adjuvant setting. For metastatic, single versus combination, the debate is very clear that combination is not superior to single. Palliative intent hormonal intervention is there, and aromatase inhibitors and progestins and LHRH agonists, 3 options, but AIs are the best option. BRCA mutations in 5 to 8% or 10%, novel targets are being explored. Thank you, and sorry for the delay of 2 minutes.
I have a question.
I don't know if we have time for question. Quick question.
So regarding the role of CRS for relapse disease, what is the good imaging to assess resectability? One question. What is a good amount of disease-free interval when you would consider for CRS? And what extent of surgical resection is you would consider as valid, considering that it's an aggressive disease? The recurrence can be involving a vault mass, multiple mesenteric deposits. She may require exentration to achieve complete resection, multiple bowel resections. So what amount of surgical resection would you consider as resectable, and how would you plan?
So there is no doubt surgery is first line, and surgery is again and again and again in sarcoma. That is very clear. So regarding resectability, you can resect where you can get the planes, and as regards exentration, that's the only place, or a totally disseminated disease as in lung or as in complete abdomen. That's a different view. Otherwise, all cases, I mean, we would subject it for resection. And talking about exenteration, that is for the patient also to, it's a huge thing for the patient to decide. So that we have even given, chemotherapy, reduced it if it reduces and then resect it. But resect either before or after.
So I think what we are trying to say, biological nature of the disease, if it's something very aggressive, you need to have discussion with the patient before doing very aggressive mutilating kind of surgery amounting to exentration. I would say no. But yes, if it is resectable, disease-free, we generally take at least 12 months or more, and oligometastatic disease completely resectable. That should be the target. Thank you very much. And on behalf of all our panelists and co-moderator, I would like to thank organizers for giving us this opportunity. Thank you very much.